Good afternoon, and thank you everyone for attending today's webinar, End of Life Care, brought to you by Gina Campanella of Campanella Law Office. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located on the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar, and a recorded version will be available on the website for members only. Again, NJMGMA would like to thank you for attending, and I will now turn things over to Gina.
Thank you, Dawn. Good afternoon, everybody, and thank you for attending. I am hopefully this afternoon going to give you a bit of an overview of just the legal side of end-of-life care, and hopefully have plenty of time left at the end for a few questions and answers. Again, as Dawn said, my name is Gina Campanella. I'm the principal of Campanella Law Office. I have been practicing for over 10 years, specifically in healthcare transactions and regulatory law for the majority of my career. And as we're getting into the development of end-of-life care as something that insurance companies and payers are really seeking for providers to focus on a bit more, we find that we're really having more and more of these types of discussions requested. So I guess we will just dive right in. The legal side of end-of-life care is essentially documentation. Legal documents that control end-of-life care decisions include advance directives, and there are two different kinds of advance directives. One is called a proxy directive, which is also sometimes called a durable power of attorney for healthcare. The other is called an instruction directive or a living will. I will get into the differences between these in much more detail as we go forward, but a proxy directive at its simplest appoints someone to make decisions. Instructive directive actually says what the individual would like those decisions to be. Do not resuscitate order is exactly what it says. It's a medical order that indicates that a person does not wish to be resuscitated if they should find themselves in that situation. And then we also have the newest one to the table, which is New Jersey PULSE, which stands for Physician's Orders for Life-Sustaining Treatment, which, like a DNR, is also a medical order. The American Medical Association does have a clear policy on end-of-life care. I have included a link to the full policy. If the links are not live when you do have this emailed out to you, you can cut and paste. That'll work as well. And provisions specific to these legal documents have been duplicated on the slides for you. I won't take up time reading them out to you, but they basically are very valuable because they do assist physicians and providers in determining when these particular types of orders should be used, when patients should have these types of orders and things brought up to them, who they're appropriate for. Okay, and this is a bit more American Association of Physician Assistants policy. I also include this as well, just because we have some of the documents can be witnessed by a physician assistant, a nurse practitioner, or a physician. Now, advanced directives, getting a bit more into the definitions of what each of the documents are. A proxy directive, which, like I said, is also sometimes known as a durable power of attorney for healthcare. This is wherein your patient will appoint another person to make his or her healthcare decisions should he or she ever be incapable of making such decisions his or herself. Okay, this type of a document, this is for anyone. This is for someone who's completely healthy, any age, any illness or lack thereof can be executed by any individual at any time. It does not go into effect until the individual becomes unable to make his or her own healthcare decision. And it has the same effect for a permanent or temporary inability. What this means is a lot of times this will be the type of a document that people will come to an attorney to have them fill out rather than come to their physician to discuss. They will come to their physician or their healthcare provider to discuss what the different choices mean. And I actually advise many of my clients to do so. But basically, the number one question I get is, but I don't want this person making my decisions if I can make my decisions myself. And that is not what this document does. It's never what this document does. What this document does is it simply says that if I am either permanently or temporarily unable, either mentally or physically, to make my own healthcare decisions, this is the person I would like appointed to make those decisions. People can appoint a primary person. They can appoint a secondary person if that primary person is somehow unavailable or incapable or refuses to do so. But there cannot be more than one person. You can require that a proxy consult with others, but there cannot be more than one proxy, because they do the last thing that a provider or a hospital or anyone would want is to be in a situation where they have proxies fighting over the decision to be made. Okay. When you are speaking with your patients about proxy directives, you should definitely advise your patients to inform their proxy and any backup proxies that they have been appointed as proxies. It's stressful enough when you have someone whose loved one is in this situation, and then all of a sudden they find out they're the proxy, and they say, "Well, I'm not really sure what they know. I mean, we had a conversation about it once over a couple drinks. How do I even know that that's really what they wanted?" The patient should have a clear conversation with the proxy, the backup proxy, discussing what their expectations are or their requests or desires are. If the proxy doesn't know, if you have a situation where you have a proxy and you have to discuss with them what needs to be done, and this conversation hasn't occurred, then the proxy just needs to make that decision based on the patient's best interest. And that is the only level of care, I suppose, for lack of a better phrase, that the proxy will be held to. An instruction directive is a document that's also commonly known as a living will. Now, a lot of times you will see a proxy directive and an instructive directive combined in one document. This will be the document you'll see where it'll say, well, in these 3 or 4 scenarios, this is what I want. And then if there's a scenario that I have not contemplated above, this is the person who I want to be my proxy. That's the most common document you're going to see. So the living will section, or the separate living will document, this is where the patient makes specific directives and includes specific scenarios in which he or she would not want life-sustaining treatment. For example, this is where the patient will say, if I am in a coma and there is no chance that I will recover without significant brain damage where I can lead a normal life, I do not want to be kept alive by artificial means. I do not want artificial feeding. I do not want artificial nutrition, things of that nature. Or this is where the patient can say, I want absolutely everything. You know, until my heart stops bleeding, my personal belief, or stops beating rather. My personal belief is that I have not passed away. I want everything possible to keep my body alive. And then this document can also include a general description of what the basis beliefs or values of the patient would be. So if they do appoint that proxy with a combination document in a living will, they can say, these are the 3 or 4 scenarios I've already contemplated. This is what I want in these scenarios. And then in the event there's a scenario I didn't contemplate, this is who I want to make the decision. And this is a summary of just my general beliefs about life, death, you know, spirituality that I would like the person to base their decision on. Some common concerns that individuals have with advanced directives. Some healthcare facilities, such as hospitals and surgical centers, are required under various statutes and regulations to ask patients if they have an advanced directive if they are going to be undergoing any type of procedure that involves anesthesia or anything like that. Although they are required to ask if they have them, and they might ask to have them on file, that no patient can be required to have one as a condition of care. So no one has to have an advanced directive. An advanced directive can be executed in any state, and it'll still be valid in New Jersey. I have clients come to me a lot, and they say, listen, you know, we just moved here from Florida, or, you know, we're semi-retired in Florida, but we come up for the summer. All of our documents have been executed in Florida. What happens if we come up for the summer and we get sick? Not very uncommon scenario in this area of the tri-state. And as long as the documents have been executed properly in the other state, they will be valid in New Jersey. Once a patient regains the ability to make his or her own decisions, the advanced directive is no longer of any effect. The proxy no longer has any authority, and anything on that document is no longer authoritative over the patient. That's another concern patients have. They say, well, you know, once this document goes into effect, does that mean even when I get better for the course of that illness, I can't make my own decisions? No. The moment that patient is able to make his or her own decisions again, the document is done. It no longer has any authority. Some definitions, common definitions of terms in the advanced directives: life-sustaining treatment. Legally, this is defined as any medical device or procedure that increases life expectancy by restoring or taking over a vital bodily function. This includes drugs, machines, surgery, therapy, or any artificial nutrition or fluids. And I'd like to point out that it does include surgery or therapy, because a lot of times people think life-sustaining treatment is just the drugs, the machines, or the artificial fluids and nutrition. But it's important to note that the legal definition does include surgery and therapy as well. Sometimes people don't think that that's included just because it's much more of an active action and a step to take, more so than artificial fluids and nutrition. Permanently unconscious, that means permanently lost the ability to interact with the environment and you're completely unaware of your surroundings. And then terminal condition, this is defined as the final stage of a fatal illness, disease, or condition. This does not require diagnosis of any specific amount of time left to live. When we start talking about PULSed, we're going to talk about how it was envisioned to be used for individuals who are in final stage of fatal illness, and they do apply some time frames to that. But the actual legal definition of terminal condition in advanced directive does not require any specific amount of time left to live. Okay, some technicalities. It is not necessary to retain an attorney to complete an advanced directive. Obviously the same way that you would advise your patients to consult with you, I always advise people that if they do have the luxury and the ability to consult with an attorney, just so they are clear on what these legal definitions that might be different than definitions that we use in everyday colloquial language are, and be sure of the decisions they're making and the documents they're signing, but it's certainly not necessary. I would rather see someone have an advanced directive, which is filled out as the form that you can download from the State Department of Health website, than not have one at all because they felt they could not afford the time to go over it with an attorney. In order to be valid, it must be signed and dated by the patient and either be notarized or signed and dated by 2 witnesses. Okay, so either one notary or 2 witnesses who are not notaries. The individual named as a proxy cannot be a witness. This is very critical. A lot of times, people stick very close to their inner circle. They have their proxy is also their friend. They would want signing or witnessing such a document. You definitely cannot have the proxy be a witness, because if there becomes a question where that individual might not have been of sound mind when they were appointing that proxy, the proxy has a conflict of interest to also act as a witness, and it could invalidate the entire advanced directive. An advanced directive can be replaced with a new advanced directive at any time. This is why dating all advanced directives are critical. I like my physician clients because and my healthcare provider clients, because dating things is so critical to healthcare practice that I find you guys are actually really good about dating things, but most people aren't. You can have a big bold line that says date right next to a signature line, and people will just ignore it. Dating all advanced directives is critical. You might have someone who, in 2012 believed that they wanted absolutely everything done to keep them alive, and then perhaps had an experience with a loved one that changed their mind. They signed a new advanced directive in 2014, then they themselves become ill to the point where they need to use their advanced directive in 2015. And then you have 2 competing advanced directives. If they're not dated, no one knows which one to use. And by the time it's determined which one should be used, it could already be past the point where that person's wishes have already been violated. And advanced directives can also be canceled verbally or in writing at any time. This is a little bit tricky. What this means is you could be caring for a patient. That patient could be, going in and out of consciousness. Perhaps when they are unconscious, their proxy comes in with the advanced directive and says, okay, I'm in charge. The person comes back into consciousness and says, I do not like the decisions my proxy is making. I'm revoking that advanced directive. That is a valid revocation. And what I recommend to my clients is that they make a note of it in the chart. They make a note that they had the oral conversation, that the patient was of sound mind when they did revoke it. And as soon as possible, they get something new in writing by that patient, either a new advanced directive or something in writing by the patient saying, I revoke my advanced directive. Have them sign it and date it, and keep that in the patient chart. Some technicalities, like I said, while many patients choose to have an advance directive that includes both the instructive and the proxy, it's not required to have both, and each can be entirely independent without the other. But a patient can only have, like I said previously, a patient can only have one proxy, but he or she can require that the proxy consult with other named individuals before making any decision. The example I always use is my father is a physician, so presently I have my father named as my proxy. However, I do have a requirement that he has to consult with my mother before making any decisions. I cannot have them both as proxies, and unfortunately just the medical degree was what flipped the coin on that. But you can require that they have to consult with other individuals. One thing that proxies get very nervous about and they get very upset about, if you ever are in the situation where you're dealing with a proxy, they are frightened to make, and I see this more often than not, the proxy is frightened to make a decision that they know the patient would want made because they are frightened that they will be held responsible, the proxy, for the medical costs. A proxy cannot be held responsible for any of the patient's medical costs. So it takes money off the table, it takes finances off the table, it takes that concern completely away from the proxy. They are supposed to be making their decisions based solely on the best interest of the patient. Sometimes how I advise patients to select a proxy. A proxy is not necessarily always someone's spouse, someone's sibling, someone's best friend. A proxy should be someone who knows the patient's wishes, values, and beliefs and desires very well. So you might be saying, okay, well that sounds like my spouse or my best friend. This is where it gets a little tricky. A proxy should be someone who will follow the patient's wishes even if they conflict with the wishes of the proxy. That's where things sometimes get a little bit sticky. And you also need someone who can be a very strong advocate for the patient even when confronted with difficulty from other friends, family members, or loved ones. So when choosing a proxy, they need someone that's not only going to be strong enough to make the decision they know that that patient would want made, even if it conflicts with their own beliefs, but they're going to have to be strong enough to stand up to the pressures of other friends, family members, loved ones, whose beliefs may conflict as well. So you want to make sure you make a very wise decision. You don't want to make the decision that's just going to make the proxy happy or make everyone happy, because it is the patient's health care and it's quite frankly the patient's life that's in the hands of the proxy. I just like to include the sample forms. Sometimes when I do this presentation live, these sample forms are not very legible. I'm hoping because we are online that everybody has a nice big monitor. And then when Dawn emails out those materials later, you can also take a better look at this. But all of these sample documents are on the New Jersey State Department of Health website if you did want to download them. So this is just a sample of a proxy directive. Okay, you can see where there are different signatures required, things of that nature. Instruction directive. This gives examples of some of the instructions that individuals might want to include in an instructive directive. Typically, as a rule with these documents, if something is left blank, it is assumed that the patient wants all of the proposed care in that section. Do not resuscitate orders. These are now the difference between all the documents we just discussed and the documents we're going to begin discussing now. The documents we previously discussed, these are not medical orders. These are simply legal documents that provide the proxy with instructions. Okay? Do not resuscitate orders. This is an actual medical order, like any other medical order, an order for medication, an order for a treatment, an order for a therapy, and they have to be treated as such. A do not resuscitate order, which is abbreviated as DNR, this is a medical order, and it prohibits the automatic application of CPR in the event that a patient goes into cardiac arrest. These are typically used for patients who are very ill and are either not likely to survive CPR, or if survival is a possibility, the survival is only going to prolong their pain and suffering and ultimate death. So this is typically something you're going to see used for that patient that is at the end of their long-term illness, something of that nature. Okay, the important thing to know about DNR orders is that they can be implemented both inside and outside of the hospital. If you have an individual who is at the very end of a long-term illness and they choose that they want to go home and be home in their final days, they can still have a DNR order. What I recommend to all of my clients, and what I would suggest you recommend to your patients when discussing these things with them, is that if there is somebody who is at home, like I said, living out their last days either at home or in a facility that's not a hospital facility but it's a residential facility, that DNR should be on the bedstand, on a magnet on the fridge, somewhere where if something happens and emergency individuals do have to be called, because they do have to be called, whether CPR is going to be happening or not. You can immediately present them with that, and EMS individuals are trained to follow DNR orders. For in-hospital DNR orders, this could be the patient requesting that the physician write a DNR order, or such an order is documented in the patient chart as a result of wishes expressed in advance directive. Now, here's where the documents connect. A patient's in the hospital, they have an advance directive, they don't have time. It's something sudden. It's something that has come on, it's not something that's long-term. The patient hasn't really developed a relationship with the physician enough to say, I want a DNR order in my chart when I'm at the end. The physician is now presented with an advance directive. The advance directive says, I do not want to be resuscitated. What that physician should be doing is putting a DNR order in the patient chart based on that advance directive. The order, once consented to by the patient, must be clearly documented in the patient chart. If you're putting the order in based on an advance directive, you want a copy of that advance directive in the patient chart. In the event a patient with a DNR undergoes a surgical procedure, he or she does have the option of suspending or canceling the DNR for that surgical procedure and then reinstalling it after. Again, it's all about documentation, timing, and dating. Cancellation and reinstitution must both be clearly documented in the patient's charts. And I know that hospitals, ASCs, a lot of things, they already require that all orders and entries and charts be timed and dated in many scenarios, but I cannot express how important that is, especially with something like this. And we say, when would that happen? Okay, that would happen if somebody does have a terminal illness, but let's say they're going in for a root canal or something like that. They're still living a good quality of life, and they say, well, listen, this is just a root canal. I want to be resuscitated if something happens with my anesthesia during my root canal. Then they could cancel the DNR and then reinstate it, because the DNR wasn't intended for that. It was intended for advanced complications of their terminal illness. Out-of-hospital DNR orders. Like I said, in New Jersey, physicians are permitted to write DNR orders for patients who choose to spend end of life in home, or like I said, a facility rather than the hospital. And again, part of the reason why New Jersey has taken the action to permit physicians to write DNR orders in these scenarios is because a lot of times you would have people who would have trouble in end of life at home, and the family and friends would be very fearful to call 911 for assistance because they would be terrified that they would give the patient CPR and it would just prolong their suffering. So now, like I said, EMS providers in New Jersey are trained to recognize and abide by DNRs. And this relieves a lot of stress for patients and their families that if there's some other type of medical emergency, or even if it is a cardiopulmonary medical emergency, they can call EMS and they don't have to be fearful that CPR is going to be unwantedly administered. Hospitals and physicians have developed special DNR order forms for home use. And then patients can also get a DNR bracelet. It's the same as you would for like a diabetes bracelet or something, or a peanut allergy bracelet or something like that. And like I said, it's all about the form being prominently displayed and readily available for EMS personnel. A DNR order only means no CPR. All other treatments are authorized and should be provided. An advance directive alone, like I said, is insufficient to function as a DNR order. The DNR order must be requested based on the advance directive and must be documented in the patient chart based on the advance directive. And again, like we've said repeatedly, EMS personnel in New Jersey are trained to honor DNR orders. Now, there is a national movement for something called a practitioner orders for life-sustaining treatment. That is POLST. In New Jersey, it's called POLST. In New Jersey, it's called MOLST, Medical Orders for Life-Sustaining Treatment. The national movement's first focus was to get something like this integrated in every state. Now they're trying to get it nationalized. There still are a few states that don't have it. But this is kind of something where they're trying to expand the physician orders, and they're trying to expand it to out of hospital. So just a little bit of background on POLST. In 1991, the National POLST Paradigm was formed. It began in Oregon. As many of us know, Oregon is a very progressive state as far as end-of-life care. And this was done after medical ethicists discovered that patients' end-of-life wishes were not consistently honored. And a lot of this could do with the separation between advance directives simply being legal documents and not medical orders. This initiative quickly spread to other states. Some of the first states to pick up on this and form their own programs: New York, Pennsylvania, Washington, West Virginia, and Wisconsin. In September of 2004, the National POLST Paradigm Task Force convened on an informal basis with these initial members, and talks began on an informal basis for the purpose of exchanging ideas for these programs in various states. The task force was formalized. National POLST office is now headquartered in Oregon, and standards for POLST programs are being developed by the National POST Office, and this office offers support and resources to all state POLST programs. Here's the link for that National POLST office. You can go there. You can find out anything you want about POLST, see what the different programs in the different states are. You may have to advise clients to consult that because, as you'll see, POLST is not like advance directive. POLST is very difficult to get across state lines. You have to have basically, not only does it have to be executed in accordance with whichever state, both states' requirements, but you also have to have the state have something on record saying that they will accept an out-of-state POLST. New Jersey's POLST program is currently categorized as a developing program by the National Paradigm. It was signed into law by Governor Chris Christie in December of 2012. And this is a link to the New Jersey POLST program website. Like I said, with all the links in this presentation, they should be live. If they're not, cut and paste works perfectly well. New Jersey's POLST program information on POLST and the actual POLST itself are available online in English, Spanish, Korean, and Vietnamese. These were determined to be the top 4 languages that were required in New Jersey for access to this program. Educational resources are available online for physicians, practitioners to use with their patients, and also educational resources that you can direct your patients to if they want to go home. Think about it. Now, who is POLST for? Previously, we said advance directives are basically for anybody. I'm 36 years old, perfectly healthy. I have no major medical problems. I have an advance directive. It would be very inappropriate for me to have a POLST. POLST is for seriously ill patients with life-limiting advanced illness, advanced frailty, significant weakness, difficulty performing daily personal activities, the possibility that they're going to lose their decision-making capability within a year. So here's where I said now, we're putting time frames on it. And again, these are suggested time frames. This is something for you to discuss with your patient, but POLST is recommended for patients that anticipate that they're going to need to use the POLST within the year. Chronic illness, frequent contact with the healthcare system, or illnesses requiring residence in long-term care facilities. POLST is very much not for healthy patients, medically stable patients, patients who may have functionally disabling problems but still have years of life expectancy, or individuals seeking to replace an advance directive. A lot of times, especially back in 2012, 2013, when this was very new, I would go out and give presentations, and they'd say, okay, well then why do we even need advance directives anymore? And the answer really is because with an advance directive, you still have that one step that it has to be taken between the advance directive and the medical order. If I made an advance directive 10 years ago and I just haven't bothered to update it, my proxy can say, no, I know for a fact that these aren't her wishes anymore, and make different decisions based on what my wishes would be. POLST is not supposed to meant to replace an advance directive because it's supposed to be reviewed frequently and updated frequently depending on the progression of the person's illness. Okay, this is just a little bit of a chart that gives a comparison between POLST and advance directives. Like I said, the most important thing is that advance directives are not medical orders. You still have to have that next step, and POLST are medical orders. Once a POLST is filled out and signed, that is good as a medical order in a chart. POLST and DNR, how do they interact? A POST form will completely replace and invalidate any out-of-hospital DNR form previously filled out by a patient. Because a DNR, like a POST, is a medical order, and it would be invalidated by any subsequent medical order. This is an example of what the POST form looks like. The state of New Jersey does require that it is printed on this green paper. If you print this out from the New Jersey POST site on a white piece of paper, it will print in background green. That's acceptable. Copies of POST forms don't have to be in green, and copies are considered valid as the original. But it is suggested that you do have the original on the green paper in the patient chart, like I said, on the fridge, on the bedstand. It's specifically made in a different color for easy recognizability by care providers. This is the front. We're going to go through each section briefly. This is the back of the POST form. You can see it does have instructions for the healthcare professional on how to assist the patient in filling it out. Okay, and then I like to point this out because a big part of my practice is also HIPAA regulatory work. I don't want anyone who is working with a patient who has a POST form to ever be fearful that they can't share that POST form because of HIPAA. There is a specific part of HIPAA that permits disclosure of the POST to any other healthcare professional as necessary. You don't need separate permission from the patient. Okay, the POST must be signed by the patient and the patient's physician or APN. Like I said, special HIPAA authorization is not needed to share a POST form with other healthcare providers, and any section which is not completed is interpreted as an election for full treatment. And we'll see what the different sections deal with now. Section A is goals of care. This is actually not a medical order section. This is the only section that's not a medical order. This section is basically intended to let the patient kind of review and reflect on what their goals are and what they want to achieve with their POST. For example, the patient can say, well, I just want this POST to give me as much longevity as possible. I want this POST to keep me alive until they can find a cure or until I'm in remission. Or I just want my POST to allow me to have as much quality of life as possible, and then when my quality of life declines, I'm done. Some people even say, I just want to make it to my grandchild's wedding in 6 months. I want to be able to eat solid food and putter in my garden. Once I can't do that anymore, that's what I consider quality of life. If I can't do that anymore, I consider myself no longer having sufficient quality of life. Okay, so this is really the section that you're probably going to spend the most time discussing with your patients, what their goals are. Then, once they've had a chance to reflect on these goals, we move on to the sections which are medical orders. Section B deals with what kind of medical interventions the patient would want. Section C deals with artificially administered fluids and nutrition. Section D is specifically for CPR. And again, these sections are all now medical orders with options of care selected by the patient. Section E is authorizations for a surrogate to modify or revoke the POST. So again, you have somebody appointing a surrogate, and all of the advice about appointing a surrogate that I would apply to advanced directives, I would also apply to POST. Okay, and then Section F, authorizing signatures and an option to give an anatomical gift on death. Who gets copies of a POST? Now, and you can look at the POST form for more specific information on what those different sections really get into. Who gets copies of a POST? Primary care provider should always get a copy. The designated proxy and any alternate proxy should get a copy. Family members should have copies. Any treating provider should have a copy. And any facility to which the patient is admitted for either acute or long-term care should always have a copy. This is why they say copies are fine. And you don't want to have a bunch of originals floating around, because then you can say, well, they dated this one on December 12th, they dated that one on December 13th, and there might be differences, and what are we going to do? So that's why copies are accepted. But you want to just make sure that everybody has a copy, because again, this is like a medical order. This would be like them getting admitted into a facility, and then the physician or the care providers do not have their entire medical background. Now, one of the things that many third-party payers have been taking into account is, physicians are spending their time with patients going over these types of advanced care planning scenarios, and physicians should be getting paid for their time. that they're spent with patients going over advanced care planning. So I use Medicare as an example just because that is what most patients who are probably going to be discussing, hopefully, these advanced care planning issues, that will probably be their primary payer. You can look to each of your individual payers with which you're a participant to see if they also have codes or payment scenarios for discussion of end-of-life care. But beginning January 1st of this year, the Medicare Physician Fee Schedule now includes codes to bill for physician time spent with patients discussing end-of-life care planning. You have code 99497. This covers your first 30 minutes of discussion with the patient, including helping them fill out forms or explaining their different options. And then 99498, that's for additional 30-minute blocks. So for example, if you, and obviously I would advise you all to defer to whoever you use for billing and coding. That is not my area of expertise. This is just for an example, for an overview. But you could essentially, if you spend an hour with a patient going over their different options, even if you don't help them fill out the documents and they're just asking a lot of questions about what the different medical therapies mean, to then go back to their attorney and fill out the document, you can now bill for your time for that, and appropriately so. Again, with any other billing, especially with third-party payers, you need to make sure that the minimum amount of time necessary to bill these codes are spent with each patient. And again, I would defer you all to go to your billing and coding person, determine what those minimum amounts of time are. It could be, if you spend 5 minutes with them, you can bill for the 30-minute code. I don't think that's likely the case with Medicare. You might need to spend at least 20 minutes with them to bill for the 30-minute code. You do want to make sure that you spend the minimum amount of time necessary to bill those codes with each patient. And again, documentation, documentation, documentation. You want to make sure that you document the time you start discussing with them, you document the time you finish discussing with them, so you do have a record of that minimum amount of time being spent. There is no frequency limitation regarding how frequently these codes can be used. However, again, you want to make sure you document to back everything up, because this is not something where you're going to have medication dispensed or test results or anything like that, or it's something where there is a typical amount of time that's spent. In these types of scenarios, you could have a patient who gets all the information they need in 10 minutes. You could have another patient that wants to come back and see you 3 weeks in a row for an hour at each clip, and they still don't feel confident in their information and decisions they're making. Again, as is with the key with all billing and coding with third-party payers, you want to make sure you have the documentation to back it up. Medicare will also expect to see that the beneficiary was given a clear opportunity to consent or decline to advanced care planning services. You don't want to end up in a scenario where you have the patient in the office for a flu shot and you say, hey, while you're here, let's have a 20-minute conversation about advanced care planning services. This is something more where you want to say to the patient, look, I can now offer you these services. I can offer to have a discussion with you. I would recommend from the legal point of view that you actually have a consent form where you provide it to the patient and say, my physician, my provider, has advised me that I can decline to discuss advanced care planning services. I have requested to discuss these services, or I have consented to discuss these services. Have the patient sign it, keep it in the patient chart, upload it to your EMR, whatever you have to do. I think that's the cleanest way to do it. I also think that just having the physician make a note in the chart, I offered to discuss these advanced care planning services with the patient. I did tell them they can decline to discuss these services, and they consented. Or the patient approached me and asked me to discuss these services, and they gave me their consent to discuss with me. I do think a physician note in the chart would also be considered sufficient. I have no reason, this is all fairly new, and we've been seeing no reason yet to think that that wouldn't be sufficient. But again, I always think the cleanest way is to have the patient signing a form. So like a user-written consent form, have the patient sign that consent form. Again, I cannot say it enough. Document, document, document. All physicians and providers should consult with Medicare and our private insurance contacts regarding the program-specific documentation requirements to bill for these services. Like I said, this is a sticky area. You're basically billing for having conversation. As far as these companies, the third-party payers looking for results of the conversation, if you're billing, and if you have one of those scenarios where you're billing, an hour a week for 3 weeks in a row, they're going to want to see that you either helped the patient fill out their forms, that the patient made a significant change to a prior form and executed a new form. They're going to want to see extensive documentation of what the patient's questions were, what discussions you had, things like that. So you do want to make sure that you have all your documentation in order the same way you would with anything else, but quite frankly, even more so with this, because there really isn't anything tangible with this that you can show as a result of a patient, seeing that patient, like a test result or a lab report or something like that. And I was trying to go through quickly so we would have plenty of time left for questions and answers. So Dawn, did we have any questions?
Thanks, Gina, and thank you everyone for attending. I don't see any questions right now, so I'll give it another minute and see before I close. So if anybody has a question, please get them in. Gina, you were very thorough, so I appreciate that.
Thank you. And also, my email address is there as well. So if anyone thinks of a question, if you're, going over the materials later, I'm always happy to answer emails with questions.
Thank you. Okay, everyone, I don't see any questions. Just as a reminder, I'll be sending the presentation out later today or tomorrow, as well as the recorded version will be up on the website. Thank you again for attending, and our next webinar is in 2 weeks on the 27th. Have a great day.
Thank you. Bye-bye.